This is going to be my presentation. Thank you so much for Dr. Branch and Dr. Krinsky, who helped me pick this case and helped me prepare. This case initially was built with more fellows in mind, so we may skip over some parts that you guys already know quite well, I would imagine. But we'll get right to it. So this is the patient. He's a 62-year-old guy. He has AML, has had a bone marrow transplant, has GVHD, has a myriad of chronic conditions. And he came into the GI clinic for some substernal chest pain and worsening pill dysphagia. He does have acid reflux, which he says has been well controlled on his PPI. And he has as well a history of oral candidiasis, but never esophagitis, and we don't see any thrush when we take a look. He's had a negative cardiac workup and relatively recent normal upper endoscopies in 2020 and 2021. So we sent him for an upper endoscopy. So this is some photos from his first EGD. He had a little bit of Barrett's esophagus, a stricture in his distal esophagus, which we dilated, and then on withdrawal in the upper esophagus at about 20 centimeters from the teeth, we saw this sort of nodular polypoid area, which we biopsied, of course. The pathology results came back with superficial fragments of at least squamous cell carcinoma in situ, which is not surprising. So we bring him back and we do a repeat upper endoscopy with an ultrasound. And again, at 20 to 21 centimeters, there's a nodular lesion, which we measured 15 by 10 millimeters in size. And we did an EUS, which was essentially normal. We couldn't see the lesion on the EUS and no lymphadenopathy in the area either. So I built this as like sort of a question, similarly to our last presentation, which is what are the therapies that are available in this situation to deal with this squamous cell carcinoma?
Cut, burn, or freeze?
That's it. That's it.
But which one do you prefer?
Yeah, I think.
So, actually, before going to
Yeah,
that,
can we go back?
Go back.
Yeah, let's go back, how
Yeah.
you would approach it after
Yeah, how you would
saw it.
And it
approach
looks
it.
different in the first,
Yeah.
and
I
the
know.
second.
No, first, as soon as she showed the slide, it looked like a squamous.
Yeah,
yeah.
And,
Okay.
so
So
even,
go back,
like,
right
look at
now.
that, that's
Yeah.
all
So what
squamous.
would you do now?
So here, this is one that's fine, biopsy. Let's go to the next one, and because it's the same thing.
And now you see.
You
Yeah.
take a look at it, like, what is that? Number one thing you wanna know is what is the extent of squamous cell carcinoma?
Exactly.
It is totally different from adenocarcinoma. The therapy is, endoscopic therapy is totally different from adenocarcinoma. Here, you wanna see extent, what I mean is the circumference, not really the length. Length is like, usually can deal with that. But when it is, this squamous cell carcinoma has much more lymphovascular invasion, 30% are sometimes, as compared to the adenocarcinoma. Circumference goes to more than 50%. Don't even think about endoscopic therapy, that's gonna be unsuccessful. So that's where you start with. Then you can get to the, what treatment you are gonna do. So, and that is like how you do that. Like, by looking at it endoscopically, high definition, you may miss it. Ultrasound is the most useless thing to do in these
Just
patients.
to rule out lymph nodes.
Lymph nodes,
So
yes.
for that purpose, the
Yeah,
T
but
stage
that,
is-
but not, yeah, it's just does not tell you about if it's a, like mucosa, deep
No.
mucosa.
The lesion, yeah.
But it definitely would, because these have a lymph node metastasis, so yeah, point well taken. If you see that, then that is helpful. But what you do is you have to do a staining of any supplements. And how you do that staining is with the leuco.
Mhm.
And so that's what you need to do. That would give you a much better extent, and that would drive the therapy, endoscopic, radiotherapy, such.
But if it's in situ, again,
Well,
depends on
if-
who you are, even if it is more circumferential.
I think, yeah,
What
then
do
it
you
goes.
They
do?
do
Lose
ESC.
mouth.
I need to see the lugalls and see how.
Okay.
Yeah.
I'm not the Japanese ESC expert where I'm.
So,
or
like,
Dennis.
you can do endoscopic therapy, but you have to take a look at it,
But
how
I-
successful that is.
No,
gonna
no,
be
and
for
also
the long-
that might warrant a bigger
Yeah.
discussion, right, with
Yeah.
the tumor board before
Tumor
you
board,
embark
exactly.
upon this. But if you think it is localized, then resection can help give you staging information, right? So, and with squamous cell, because of what Dr. Hassan already said, higher risk of lymphovascular invasion, ESD is preferred because you get deeper into the submucosa and you get that LVI information.
Mhm.
So I think endoscopic biopsies can sometimes underscore what
Yeah.
really is
Yes.
there.
Yeah.
And I realize the lesion is very high, but a linear scope or even the EBUS scope can really get you the depth of penetration, which is super important in terms of how you approach
Well,
them.
but
It can, but
it's
it
not
is
as
like, does,
simple.
sometimes it overestimates,
Yeah.
sometimes it underestimates. If you really want to do the depth of invasion and you are not sure, you have to resect it
Yeah.
endoscopically.
There are those,
EUS, like, there are like we have a good literature on that, like when it just comes to the depth of invasion, unless it's involving clearly muscularis propria or it's a T3 lesion,
Yeah.
anything less than that really is hard to really have an accurate sensitivity on that. And,
So
you
you
could
could,
try those
uh,
high frequency mini probes, like 20 megahertz, but good luck. I mean,
Yeah.
we don't have, we have it, but it takes like 10 years to find it.
No, and
Never
also
do
the
it. It's so
imaging
bad.
is
So
so
bad.
bad
Yeah.
on that.
You don't get good depth of penetration and you have to be like right on it. I wouldn't trust
Yeah,
me
we're
on
going
that.
back to the 90s.
Yeah,
No,
so-
Phoenix, what were you going
Yeah.
to say?
No, I
agree
think
to disagree.
if you see an obvious T3 lesion,
Yeah.
Yes.
EUS,
Oh, then
that's-
which
yeah.
then you're done,
Oh, yeah.
which is
Unless
not
you
great
can't
on
get
this
by it.
radar exam.
Yeah.
But a lot of T3s, you can't even get by with for you.
So-
If it's obstructing though, then you know it's T3.
Yeah.
So
That's our
if,
by
there is a
definition, by
simple
definition.
rule to that.
Yes.
If you can't pass an endoscope, it's a T3,
It's T3 at least.
minimum.
Yeah.
Plus minus enough.
Yes.
Still send them for staging.
I know, but that's what I like.
Like,
I know.
so, yeah,
I'm not complaining.
Yeah, we're not biting the
Like, yeah.
hand
And
that
then,
feeds
yeah,
us.
so it's a very, like, we actually did a study on that.
No, oh, I believe you, we're not
Yeah, I think I
arguing.
saw your
We're not arguing with the findings
So
of the study.
95%, if you cannot score,
Yeah.
pass a EGD scope easily,
Yeah,
and
no,
if you have
for
to
sure.
dilate, don't even try that, it's minimum T3.
Yeah,
But
we're
tomorrow,
not
sure, they'll
arguing.
send your
Oh,
time.
no.
Yeah.
I just wanna make sure.
And we'll still do it.
I don't dilate or try to, I mean,
No,
I just
no,
say it's at
dilation,
least T3,
Yeah.
and if I saw any
We
notes.
used to dilate, but that was causing more problems.
Yeah,
leading
exactly,
to
and you didn't get
perforation
much
and
extra information,
Did not
so.
get much.
So it seems like a uniform opinion, you go to Lugo.
Yeah.
At this,
Yeah.
Oh,
at
for
the,
squamous, there's no question. Like,
right
This is the
here.
second endoscopy, definitely, now, we
Yeah.
need to know the extent of the disease.
so maybe go to the.
We made a mistake. Spoiler alert, we made a mistake. But so yes, we talked about the options. We talked about staging, which I think everybody knows, but is good
Just
for
real
the
quick
fellows.
For the ablation though, so obviously the downfall there is you don't get histology, so you don't know
Right.
what stage it really was. And depending on what kind of ablation technique you use, you may not get deep enough to have a real effect.
Right. Okay. So this is just from the NCCN guidelines. Here are their recommendations for what to do. And it, obviously, like you were mentioning, the first step is to make sure that there's no high risk features, like things on the pathology that are concerning for poor differentiation or lymphovascular invasion, which, as we mentioned, can sometimes be hard to see with superficial biopsies, or if there's ulceration, visible ulceration endoscopically. If there are no high risk features, it seems that they suggest sort of differentiating based on size. And if it's less than 15 millimeters in size, you could either do EMR or ESD plus or minus ablation, whereas for lesions bigger, they recommend ESD, which makes sense. So we did not Lugol, which is going to come into play. We did band EMR and resected the lesion in 2 pieces. We looked at it closely afterwards. We thought we got it all, and there was no evidence of any complication at that time.
Can I ask a quick question before
course.
we move on? How do you do Lugo? What, how do you administer, like if
We're
you
gonna
just
get
get
there.
there? It will
It's
get
gonna
it.
come.
Okay,
We're
then
gonna talk a little bit about it. It
Oh,
would,
good, so
somebody-
now I
yeah,
forget, my nurses mix it up, it's a little bit diluted.
yeah.
Yes.
We're gonna talk
So
about
how
it.
do you, I mean, let's just,
I'll hold
maybe we
on my question.
should jump ahead. And
Yeah,
then we can go back to band EMR and
Yeah, we
talk
can,
about that too.
About the
Let's
Lugol?
do the diagnostic,
Yeah.
Lugol.
Yeah, let's do the Lugo.
okay, so basically, we got to this point where,
You saw the margins were.
Margins were positive, is
Yes.
that what prompted
Yeah.
you?
Yes.
so we took it in 2 pieces.
I can retract the question and
Let
ask
me-
it
so I'll
in
show
5
you.
minutes. It's all good.
Basically, we can go through this really fast. We took it in 2 pieces. So one margin was positive, but we were like is it because we took it in two pieces, or is there something left? We went
That's
back,
the problem, right?
right?
Because
When you take it in two
when you
pieces,
take it in multiple pieces, you have that question.
so we go back, we look under white light and NBI. It looks like a clean scar. But we biopsy it, of course, and the biopsy comes back with residual SEC.
Cell is the worst.
So then we were like, whoops, maybe we should have done some Lugol here. So we bring him back to do that. And there's these little patches you can see on these pictures.
You want to tell us a little bit about Lugol, Stevie?
It's in here. It's the next.
Okay.
Maybe this is just organized badly.
I'm giving you a hard time.
No, it's okay.
Everyone
So
wants to jump to the,
Yeah, we're just got no patience.
no. This is the good part. So Lugols is it's iodine basically, and it stains glycogen, and squamous lesions lack glycogen, so they don't take up the stain, and they look like a pale patch. Like you can see in this picture, in the regular old endoscopy picture, there's some erythema here at the bottom of the esophagus.
This is
But
not the same patient.
this is not the same patient. This
I
is
was
just
like,
an
oh my God, we
example.
miss so much.
No.
Thank you, Uzma, for that.
I like that you said we.
we're all a team.
Yeah. But you can see that this redness here becomes this area that doesn't take up the dye, and it really delineates problem areas. It's highly sensitive, but not necessarily specific. It has a low specificity, so there can be a lot of unstained areas. And then the other downsides to using it are that it can cause some chest pain and chemical esophagitis. So patients
I've never seen that.
can.
Have you guys seen
I've never seen it.
Supposedly this is a thing. I don't know. This is my only.
So
Yeah.
it doesn't do that many cases to be
I think
made.
it's-
True, that's
Yeah,
true.
so because incidence is so low as
Yeah.
compared to some other places, so I think maybe that is.
And also, I don't know if it's
What
related to how
catheter
much.
do you guys use to spray?
I forgot. It's
Yeah,
just a
do you have
regular
any of
spray.
them? There's a
It's a
spray
clear
catheter.
spray
No, I
catheter.
don't.
Exactly,
spray
that's what I
catheter.
It
asked.
goes like a,
Yeah, the one that sprays
Yeah,
and
it
I
sprays,
was,
yeah.
are you using that one?
I
Yeah.
forget who makes it. Is that Olympus?
I think it was Olympus.
Yes.
Yeah.
There's only one
On
on
the
the market? Okay.
to spray catheter.
Yeah, it's a
yes,
card
spray.
Yeah,
spray
same
catheter.
thing
It's
for
a
like
di-
methylene blue or say, or.
Like it's a dedicated spray catheter.
Yeah.
Julie, can I ask, do you know, I don't know the answer to this, but if you have scar from prior resection,
What will
that
happen?
not take up, because Lugol's is taken by normal squamous.
Right. I don't know the answer to that.
We still see white on
I will say, like, this is the area, and I think, the scarred area was taking up the Lugols, and these
But
little.
your scar was positive, so it's.
Yeah.
But it's more patchy than
But
the
it
scar.
I
looks
think,
like there's
these
still
little
some
patches, there were
white
4
on
little
the scar.
patches.
I just want to say also, I think that this is done so infrequently in our endoscopy
Right.
unit that the team wasn't prepared. It wasn't anybody's first thought
Yeah.
because
Oh,
it
yeah,
doesn't
we
come
have-
up that often. So
apparently-
there were, barriers to.
Mm-hmm.
It's so less common.
Yeah.
Yeah.
It's like we don't see much of
Do
it.
you
We
guys
We
see
used to
a lot
keep
of
those
No,
balls
we
in the
don't,
unit, but
even
now
though
we're not
we
allowed to,
do
so we
a
have to
lot
order
of
it.
Esophageal work.
esophageal work, do a lot of varus, high-grade dysplasia, cancer, ESD, but squamous comes very rare.
We don't see it, in-
Yeah.
I feel like more than I thought I would, to be
Oh,
honest.
really?
Something that we can
Yeah.
do and for diagnostic is confocal laser endomicroscopy with subvisial imaging. So we use that in the distal esophagus for Barrett's esophagus, so that may be helpful in this setting if you have it in your unit.
No, we have it, but I never use it anymore.
Any-
I haven't used it for
Any
squamous.
confocal rep here?
I know.
No reps here except for Cook, and he's not
Not
here.
yet, not
either.
yet tomorrow.
So,
I mean, your area of view is so, we're talking
So that,
micrometers.
so small.
And for
right?
squamous cell, it's often more
And it-
diffuse, it would be hard to screen the whole.
yeah, it's, one thing is cumbersome in a way to use that. Second is like our eyes are not really very well trained to look at those, and it gives you those goblet cells much
Yeah,
more
you don't
clear
know what
as
it is.
compared to the squamous carcinoma. So I personally have not used it. Maybe there is a use. In this one, I used my 5 years ago used to do a lot of confocal, but I got so sick of it, was not as really anything major. So I think that machine is still sitting somewhere, but nobody using it. I don't know if that would be helpful in squamous or
Is
not.
there data on squamous? I haven't.
No,
No,
only
I
thing
haven't.
I could see. But having said that,
never used it.
Because we have used that in cholangiocarcinomas and biliary strictures as well. So there is something which it shows in the cancer. For the goblet, for Barrett's, you look for goblet sensors. And so I don't know what would be the use here, but it just really hasn't made an impact.
Yeah, and you gotta get the patient to contrast it. I mean,
It's a to-do.
it's a, yeah.
Yeah.
It's an
It's
expensive
a production
to-do.
and it's
Expensive to
expensive.
do, and like we are still not confident enough
Yeah,
that we,
that we
You
believe.
call
That
it,
you
all
believe
in our
it,
response,
yeah.
yeah.
The blue balls, I believe, because I can see white.
So, yeah.
So what did you find?
So, let's see. Well, we decided
There were those,
there were 4 little patches
Okay.
that we are.
less than a centimeter.
Yeah, they were all
Yeah.
small.
Yeah. So we assumed that they were lesions,
Okay.
having not taken up the iodine, and we decided to use cryoablation to go after
And
those.
not cut more?
We did not.
How old was the patient? And I forgot.
Yeah.
I'm forgetting
That's
too.
a
I think he
very
was
good
in his
point.
60s.
Okay.
Yeah, 62.
So just
Yeah.
a baby.
Yeah.
Just a
He's
baby.
so we ablated them.
I guess just thoughts on cutting more,
Mhm.
or, because there was already scar there, you thought, but
Mhm.
some of those
Technicality.
patches, worried about stricturing.
Or I think we were worried about our concern was stricturing because of the location.
Yeah.
Mhm.
And also the esophagus is thinner, upper esophagus as compared to the distance.
So you
So
guys
if you're
more
gonna-
or less think that so it sounds like, Uzma, I don't mean to read in what you're saying, but you would consider cutting more?
I'm just always, if I can cut and get tissue for histology, that's always my first bet, because,
Right.
again, ablating over something that may have underlying cancer, it's not gonna be effective.
How
But-
proximal was it
But
again?
these look
20.
pretty, you could argue these look
So
very
very
flat,
small and
very small.
proximal.
and you're already next to a scar. So
Yes,
the
and
thing-
you're very proximal
And you're very
too.
proximal.
So it's
Yeah.
kind of just at the area where you could feel comfortable doing more, maybe band EMR.
Yeah.
Yeah, I think so. I would have tried that.
Maybe,
Yeah.
just because they're those tiny spots.
And then I
Mhm.
wanted to go back when you,
But
you know,
stricturing's a real concern, because you already have a
Right.
scar, but you could get it
So
from
when-
ablation too.
so when,
Can you try to lift it? If
Yeah.
it lifts, then you can do
That's
ASD.
it.
this,
That
yeah.
ESD, or
Okay.
even
If it
if
doesn't lift, then you stop.
even if it lifts, you can still use a band EMR. At least gives you a better
Histology.
histology and more safety to the procedure.
that's one
then
question I
you can
had about
follow up with
technique,
ablation.
because when I first learned how to do this was in my fellowship with Charlie Lightdale. And it was exactly a similar case, except we did Lugol's earlier. And then, he would mark around
Yeah.
because it would be tricky, so do a little electrocautery circumferentially so that you could identify and make sure that you're getting the margins. And then, he would lift a little bit too. And then go in and resect.
He did Kappa system.
Yes,
Yeah,
so
actually, he used band. He used the band
yes.
EMR
Yeah.
way back when, and it was the
That's on his
bander
own,
that
yeah.
multi-banded, right? So, this was super exciting for me when I first did the first case. I just thought it was the coolest thing ever. And
So
he-
what was the decision between the spray true freeze and the CO2 balloon for cryo?
That's a good question.
Yeah.
I can't remember what we were talking about in there.
That was
It's just institutional.
That's
That's
just
what
what
you
you
had.
Well, we
That
also
was
have
gonna be
the
my next question, when you decided to go with ablation, I probably might have sprayed and done true freeze, because I feel like
we
for
don't have it.
cancers or potential cancers, it gets
It's
a little
more
deeper.
data, right?
Then when it's high, you can control it, and you know they're gonna spit out a lot of it, so you don't have to worry as
Yeah,
much.
it's like because it's so focal,
Yeah.
it would be easier to point to it
Yeah.
and freeze it.
Versus
That way.
adjusting the balloon.
Adjusting the balloon.
Can you
it gives
explain
Yeah.
the difference?
The only tricky part about the true freeze, you gotta get the suction catheter on the other wall, so you're
Yeah.
treating.
It's
It's hard to spray around it.
We don't have
Change
that.
the position.
I don't think I've ever seen that.
You can, you just
Yeah.
gotta move and it comes back.
Yeah.
I feel like you can work
Yes.
around it.
Yeah, just gotta-
does.
No, you just put the catheter behind
Yeah,
you.
use a cat,
Yeah.
moves around, you can, yeah, because
It
it's a
seems like
small
it
thing.
always sits in a place where you don't want it to.
But you can,
Where
you
you
can
want.
spray it.
It's
Yeah,
also
you
the-
can,
Yeah, I
that's
can spray
right.
right on it.
It's
and get
always
behind
the
it.
thing, like what you wanna do is.
You're not gonna
I
get,
had-
that
I had
is,
a person-
that is
And
the
that's a
lesson,
universal thing.
that is the lesson.
I had a patient with epidermoid metaplasia and squamous
Oh, yes, I
dysplasia.
remember that.
Oh, but then she grew it up, I took care of most of the
Oh, I have
esophagus.
that.
It went like up to the UES into the back of the throat.
Oh, my
And
God.
she has an ENT also, but he said, no, you go ahead and take
Of
care of it.
course
So
he is.
I did spray cryo on it, and it did amazing.
Did it recur?
No, well, it's only been 6 months, but.
Okay, but still, we'll take
But
it.
the spray, I mean, even up high, because they just spit it out there, so you don't have to worry about it
What was the
building
extent?
up.
Was it quite expensive?
The whole esophagus was involved.
And
What
into
happens,
a.
what happens?
What happens?
So what
Yeah, so what
happens?
happened?
Okay, so he comes back because he's having worsening dysphagia symptoms. He actually comes back before he's due for his surveillance, and we find an esophageal stricture at the site, the same site where we did all of this action. So we dilated it, but then of course at that time we didn't do any further Lugol's, and we didn't do anything else essentially other than dilate the stricture. You can see there's a pretty good mucosal tear there from the dilation. We did take biopsies again from the area around the scar, which were negative, but of course we don't have any visual guidance in this scenario. So he's planning to return for a repeat EGD 6 to 8 weeks after.
Did we let oncology know?
I don't think so.